Okay, so morning and thanks everyone for joining. Today's academic meeting is hosted by the Division of Endocrinology. It will be presented by a fellow in our department, Dr. Constance Adams. She's a specialist physician and fellow in endocrine. So Constance today will be taking us through a case of a patient that we recently managed at Charlotte. The patient presented with hypoglycemia. And we thought that this is a very relevant topic because hypoglycemic disorders are quite rare in people without diabetes. And the evaluation is largely dependent on a thorough history and a guided workup. So she'll be taking us through an approach to non-diabetic hypoglycemia. Please feel free to ask questions in the chat box. And if you have any questions that you'd like to ask directly, you can do so at the end. The link for the CPD points will be also posted in the chat box, but that'll be at the end. So please fill that in. And without any further ado, Constance, I hand over to you.
Good morning, colleagues. I'll be discussing an approach to non-diabetic hypoglycemia. I'll start off with the case history. This is Miss LM. She's a 58-year-old lady. She's a professional nurse and a previous trauma unit manager. She presents with a severe hypoglycemic event. It required an emergency department visit where her neuroglycopenic symptoms improved with intravenous dextrose infusion. On further inquiry, she's had recurrent hypoglycemic events at home. They've worsened over the last 3 months. However, she's been feeling unwell for the past year. She has a history of fatigue, generalized body weakness, increased appetite associated with weight gain. She's lost interest in self-grooming and she's become quite forgetful. She's had so many hypoglycemic events that she now keeps glucose powder, sweet snacks, as well as sugary beverages at her bedside. And she's arranged for a relative to live with her and assist her when she's hypoglycemic. Of note, in her past medical history, she had mild COVID-19 infection 6 months ago, and she was treated symptomatically at home. She's also known with depression, and she's been on citalopram for many years, however, has had no previous suicidality. She has no other previous admissions and no other known comorbidities. She does admit to being overweight her whole life. However, she's had no surgical history, and the only medication she takes is her antidepressant, and she strongly denies using any over-the-counter medications or herbal preparations. She does not use alcohol or any other illicit substances, and she's been on unpaid sick leave since her COVID-19 infection and has a carer. On physical examination, she seems quite reliable, euthymic and reactive, gives a very good account of herself. She's well-oriented. She's got normal vital signs. The only clinical finding of note is a raised body mass index of 59. The rest of her general exam is unremarkable, and her other systems are non-contributory. So far, we've got a healthcare worker who's got class 3 obesity and depression. She's had background ill health for a year, as well as COVID-19 infection 6 months ago. At this stage, we should probably consider post-acute sequelae of COVID-19 infection, although it seems like her symptoms started before then. We must still entertain a chronic organ failure, despite her not having any clinical features of chronic kidney disease or chronic liver disease. Possibly an intentional anti-diabetic drug use. With her background of being a healthcare worker and a history of depression, it's still a strong consideration. And much less likely a malignancy because she's had weight gain instead of weight loss. So the differential seems broad at this stage, and we'll just take a step back and talk about glucose homeostasis. So as we know, euglycemia is maintained by a complex system of neural, humoral, and cellular controls. The central nervous system is dependent on plasma glucose as an energy substrate. However, other tissues like the muscle, liver, and kidney can use fatty acids as basic fuel. So this enables fasting plasma glucose to be kept in a range of 3.9 to 5.6 so that the central nervous system always has glucose. And we arbitrarily define hypoglycemia as a fasting plasma glucose of less than 3.9. However, so this is based on the level that insulin is suppressed and glucagon is increased, the physiological changes that occur. But in non-diabetic patients, hypoglycemia usually becomes significant at a glucose level of less than 3, and in diabetic patients at a glucose level of less than 3.5. In the postprandial and absorptive state, just after eating a meal in those first 4 to 6 hours, glucose is readily available, so insulin levels are increased. Insulin is pushing glucose into the liver and into peripheral tissues. However, in the post-absorptive state, food is completely absorbed, digested, and stored. So you need to rely on glucose reserves to maintain fasting plasma glucose. Initially, hepatic glycogen reserves are used with the assistance of glucagon, and eventually hepatic gluconeogenesis too. At some point, hypoglycemic symptoms will stimulate the hypothalamus. You'll experience a sensation of hunger, which will lead you to ingest readily absorbable carbohydrates, and you'll correct the hypoglycemia. However, in a state of prolonged fasting or strenuous exercise, autonomic responses are triggered that will mobilize storage depots of glycogen and fat. So endogenous insulin is the main regulator of blood glucose. However, during hypoglycemia, counter-regulatory mechanisms have to kick in to maintain glucose levels. Endogenous insulin will be suppressed at this stage, and glucagon and catecholamines will be increased. Glucagon is important for glycogenolysis initially to release hepatic glycogen stores. Catecholamines also help in redirecting glucose to vital organs. Eventually, you'll have growth hormone and cortisol being increased as well. And all these hormonal processes will promote glycogenolysis, gluconeogenesis, lipolysis, as well as ketogenesis. So glucagon is the first hormone that's usually triggered, but glycogen stores are depleted within several hours. After that, gluconeogenesis occurs in the liver and the kidney. Amino acids, lactate, and glycerol are used to make new glucose. Eventually, you'll have lipolysis, which will release free fatty acids and glycerol, and oxidation of these fatty acids will result in ketogenesis, where acetoacetate and beta-hydroxybutyrate will then be energy substrates. And these are alternative metabolic fuels during prolonged fasting. So just an overview of the system. When you've got hypoglycemia, it stimulates the hypothalamus. The hypothalamus then stimulates the pituitary gland to release ACTH, as well as growth hormone. You get a sensation of hunger as well. It also stimulates the sympathetic nervous system. And this results in increased glucagon release from the pancreas, shutdown of insulin secretion. You have increased cortisol from the adrenal gland, as well as increased epinephrine. This all results in increased gluconeogenesis and glycogenolysis in the liver, which then readily restore glucose levels. You also have adipose tissue, as well as skeletal muscle, glucose being reduced utilization of glucose, increased lipolysis and amino acid mobilization, so you can maintain blood glucose levels. This is just to depict the hierarchy of hormonal and neurological responses to a progressive stepwise reduction in plasma glucose concentrations in healthy individuals. So as you can see, at a blood glucose level of 4.5, insulin is already suppressed. When your blood glucose level falls to 3.7, you've got stimulation of glucagon, epinephrine, as well as growth hormone. At a lower blood glucose of 3.3, you really should be feeling symptoms of autonomic overdrive, as well as stimulation of cortisol. And at a lower blood glucose of 2.8, you start experiencing cognitive dysfunction. Eventually, at a blood glucose of about 1.6, you might experience coma and convulsions. So when we diagnose a significant hypoglycemic event, we must fulfill Whipple's triad. So in association with a low plasma glucose, which is usually at a value of about 3.3 or less, associated with signs and symptoms of hypoglycemia, and most importantly, relief of these symptoms when the blood glucose is raised. So some of the autonomic symptoms you might experience would be tremulousness, nervousness, palpitations, hungry, sweating, tingling, as well as more seriously, weakness, dizziness, poor concentration, confusion, seizures, and coma. It's important to establish Whipple's triad because blood glucose level could be falsely low. We call this a lab artifact. It's artifactually low because if you've collected a blood glucose in a sample of blood that's got ongoing in vitro consumption of glucose, for example, in conditions with a high cell count like leukemia and polycythemia, you might get a falsely low blood glucose. So it's always important to collect the glucose in the dedicated gray top tube because it contains a metabolic inhibitor of glycolysis, sodium fluoride, and generally get this sample to the lab immediately. We obviously don't use capillary blood glucose to diagnose a significant hypoglycemic event because many factors can cause peripheral vasoconstriction or low blood glucose on the capillary stick, as well as the actual device, whether it's been calibrated, etc. And there's a broad differential for the autonomic and cognitive symptoms. So it's not always a significant hypoglycemic event if a patient has dizziness or fatigue with a low capillary blood glucose. It's important to make sure that the glucose as corrected corrects the symptoms. So we will now be looking at an approach to hypoglycemia. And a practical way of doing it is deciding whether your patient is apparently well or whether they are ill or medicated. In the apparently well patient, the things to consider would be endogenous hyperinsulinism. If insulin levels are still detected in a patient who's got a fasting hypoglycemia, it's inappropriately elevated. And we know that it's endogenous because you're taking your insulin level with the C-peptide. The other things to consider would be whether it's accidental, malicious, or surreptitious use of anti-diabetic drugs. In the ill or medicated patient, the things to consider would be medications, critical illness, a hormone deficiency, or even malignancy. So in the ill or medicated individuals, drugs are very common causes of hypoglycemia. The most obvious ones are insulin and insulin secretagogues. They cause increased insulin release from the pancreatic beta cell. Many of the other drugs as well work similarly by blocking the potassium inward rectifier and causing increased insulin secretion from the beta cell. Common ones would be alcohol, quinine, and pentamidine. And obviously beta blockers then block the counter-regulatory mechanism. Fluoroquinolones are also big causes of hypoglycemia. Critical illness is another big group. Any major hepatic, renal, or cardiac condition can cause hypoglycemia, as well as sepsis and malaria, and in patients who are not eating. Hormone deficiency, as we've discussed, this would be loss of counter-regulatory mechanisms to correct the hypoglycemia. So anyone with a deficiency of ACTH and cortisol, as well as growth hormone. And malignancy. These are obviously non-islet cell tumor hypoglycemia. Certain malignancies like hepatocellular carcinoma, fibromas, myeloma, lymphoma, colorectal carcinoma, they have overproduction of ineffective IGF-2 molecules, and this stimulates insulin receptors, results in increased glucose utilization. That's the commonest mechanism. However, sometimes you might have such extensive tumor burden that it causes destruction of the liver or the adrenals, resulting in hypoglycemia. If the patient is apparently well, you must consider endogenous hyperinsulinism. And as we spoke about, all the accidental or intentional use of insulin or insulin secreting drugs, it's important to take a good history to consider these. The other things to consider in a patient with endogenous hyperinsulinism would be an insulin secreting tumor of the pancreatic beta cell, an insulinoma. You must consider autoimmune hypoglycemic syndrome, where there's autoantibodies to insulin or the insulin receptor. Other causes are post-gastric bypass hypoglycemia. Patients who've had a gastric bypass have rapid emptying of glucose from the stomach. They've got increased glucose levels, accelerated glucose absorption. This leads to excessive insulin secretion, which overshoots. What's usually typical about this type of hypoglycemia is that it's postprandial, so it would happen within the first 4 hours of eating a meal. And another interesting cause is non-insulinoma pancreatogenous hypoglycemia, where you've got generalized hypertrophy and hyperplasia of the pancreatic beta cells. So increased beta cell mass results in also an exuberant insulin response postprandially. So it's important when evaluating the patient to take a thorough history and physical examination so that you can rule out these causes like illness, drugs, surgery, or non-islet cell malignancy. Always important to consider adrenal insufficiency because clinical findings might be lacking. And factitious hypoglycemia, especially in a healthcare worker or in a patient who's got relatives with diabetes, because then they've got access to insulin and insulin-like medication. And then you could probably start off by determining if the hypoglycemia is fasting or postprandial. If it's postprandial hypoglycemia, it would usually occur within 4 to 6 hours of a meal intake, which is very strange. Patient will most likely have a history of having had a gastric bypass. So they would have this late dumping syndrome presentation. Usually, you could test this by doing a mixed meal test. Just have to find out from the patient what combination of food do they usually eat that induces symptoms. Give them that meal. And we normally treat this condition with dietary modifications, like low carbohydrate meals, as eventually medical GIT referral. So in the workup of hypoglycemia, as we've said, once you've established Whipple's triad, it's important to take a sample of blood during a hypoglycemic event, because this not only confirms the hypoglycemia with the formal blood glucose, but it's going to assess whether there's endogenous hyperinsulinemia. So if you're taking an insulin with a C-peptide at the time of the hypoglycemia, you'll be able to assess this. You take a glucose level, you take a C-peptide level, you take a cortisol level, as well as an insulin level. It's important that they're taken at the same time and labeled on the same specimen so that there's no doubt about it. And if the glucose level is low, as we said, a value of about 3.3 is significant for associating the symptoms the patient has with the low blood glucose. It confirms there's hypoglycemia. If the cortisol level is low, that will lead towards adrenal insufficiency, which will then work up and appropriately treat. If the insulin level is low and the C-peptide is low, this is appropriately suppressed. You must consider all the other non-hyperinsulinemic causes of the hypoglycemia. However, if the insulin is high and the C-peptide is high, that points to endogenous hyperinsulinemia. If the insulin level is high and the C-peptide is low, this suggests exogenous hyperinsulinemia, which most likely from the patient taking insulin. So once you've made this diagnosis of endogenous hyperinsulinemia, it's probably a good time to refer to endocrinology. It can happen that the hypoglycemic event was corrected by glucose-containing fluids or carbohydrate meals. So we might want to induce a hypoglycemic event if the diagnosis has not yet been established, or if the critical sample was not appropriately collected, which happens often. We normally do a 72-hour fast. So a 72-hour fast was chosen for 72 hours because it's been designed to pick up insulinomas. In the first 12 hours of the fast, the pickup rate for insulinomas is about 43%. In the first 24 hours of the fast, the pickup rate is about 66%. At 48 hours, you will have picked up 95% of insulinomas. But if you terminated the fast at that point, you'll miss about 5% of insulinomas. So the way you usually carry out a 72-hour fast is you stop all non-essential medications, especially medications that might also worsen hypoglycemia. The patient is still allowed to drink calorie-free and caffeine-free beverages, and obviously no food. The fast could be initiated at home the night before admission, depending on the patient's history and how long it normally takes them to get a hypoglycemic event. And you normally monitor the patient by doing 6-hourly collection of bloods. We usually do use a capillary glucometer as well before taking formal bloods. Once the blood glucose level starts getting to less than 3.3, you'll start monitoring the blood glucose 1 to 2 hourly. And then the fast is terminated when the patient has signs and symptoms of hypoglycemia, when the blood glucose level gets to less than 2.5, because now neuroglycopenic symptoms are imminent, or if the 72 hours has lapsed. So when carrying out the 72-hour fast, you have to be prepared, already have, IV set up, dextrose available, oral, etc. You need to have a bedside glucometer. You must have all your tubes already filled out and labeled. The lab has to be alerted to be expecting the samples. And then these are some of the blood tests we'd order on a 72-hour fast. It's a glucose, a plasma glucose level. It's an insulin with a C-peptide. We do a beta-hydroxybutyrate level. In a patient who's been fasting, we're expecting beta-hydroxybutyrate levels to be elevated because the patient is now ketogenic. We also test the sulfonylurea level. This is obviously a once-off test and doesn't have to be done while fasting. And we also do anti-insulin antibodies. These also don't need to be done while fasting. It's a once-off test as well that can be done. Then at the end of the fast, before you give the patient glucose, what we normally do is give 1 milligram of glucagon stat. Then we measure the glucose at 10, 20, and 30 minutes. If a patient has been fasting for longer than 10 to 12 hours, we're not expecting them to have any glycogen stores in the liver. So if they have a positive glucagon stimulation test where they have an increase in glucose levels after being given glucagon, after fasting for more than 12 hours, it's very suggestive that they have suppression of hepatic gluconeogenesis, and this really implies that they do still have circulating levels of insulin, and obviously feed the patient. So the way we would interpret the laboratory test in hypoglycemia, if you look at this table, the signs and symptoms of hypoglycemia, we look at the glucose level, we look at the insulin level, we look at the C-peptide level, we look at the beta-hydroxybutyrate level, we see what the glucose increase is after glucagon stimulation. We're going to have done a sulfonylurea level as well as possibly an antibody to insulin. And then we'll look at what the diagnostic interpretations are. So in this highlighted segment, if the patient's glucose level is less than 3, but they've got no signs and symptoms of hypoglycemia, we're expecting their insulin level to be low. We're expecting their C-peptide to also be low. Their beta-hydroxybutyrate level should be elevated. Their glucose increase after glucagon shouldn't be present because they've already depleted hepatic glycogen stores. Their blood test for sulfonylurea will also be negative and they'll have no antibodies to insulin, and the diagnostic interpretation for this panel would be normal. So if the patient has signs and symptoms of hypoglycemia and they've got a low glucose, if their insulin levels are elevated and their C-peptide level is low, we must suspect exogenous insulin use. If the patient has a glucose level that's low, with an elevated insulin and C-peptide level, with low beta-hydroxybutyrate levels, as well as a glucose increase after glucagon stimulation, very suggestive that they've got endogenous hyperinsulinemia. So it's important to do a sulfonylurea level in a patient that you think might be taking surreptitious use of anti-diabetic drugs. And in this case, the diagnostic interpretation will certainly be oral hypoglycemic agent use. In a patient with a low insulin level, a low C-peptide level, an elevated beta-hydroxybutyrate level, as well as a negative glucagon stimulation test, this panel is not insulin mediated. Consider all the other non-hyperinsulinemic causes of hypoglycemia. In this patient, their insulin levels are elevated, their C-peptide levels are elevated. They are not ketogenic, so ketosis is being suppressed in a patient who has a fasting hypoglycemia. They're still managing to have a glucose increase after glucagon stimulation. This is certainly endogenous hyperinsulinism. In this patient, insulin levels are markedly elevated, C-peptide levels are markedly elevated, so it's definitely an endogenous problem. Further confirmed by the fact that the beta-hydroxybutyrate level is low, as well as the glucose increase after glucagon is elevated. In a patient like this, it might be difficult to differentiate them from a patient with endogenous hyperinsulinism. If you've got access to doing antibodies to insulin, this will confirm the diagnosis of insulin autoimmune hypoglycemia. And then in this patient, insulin levels are low, C-peptide levels are low. However, beta-hydroxybutyrate is elevated. So in this patient, it still seems like the patient has hypoglycemia. The sulfonylurea level is low. The antibodies to insulin are negative. They seem to still be having a sort of insulin-mediated process, but their insulin and C-peptide levels are low. This is most likely IGF-2-mediated hyperinsulinemia, which I'll speak about later. So in our patient, her initial panel showed a glucose of 2.3. Her insulin levels were elevated. Her C-peptide level was elevated too, and her cortisol level was normal. So this was in keeping with endogenous hyperinsulinism. She had a lower than detectable sulfonylurea level, and her glucagon stimulation test was positive, as well as a low beta-hydroxybutyrate level, which confirmed that she had endogenous hyperinsulinism. At this stage, our working diagnosis was an insulinoma. The rest of her routine bloods were normal. So then we went on to do localizing studies, and CT abdomen showed a well-circumscribed enhancing mass in the head of pancreas, about 20 millimeters. She also had an endoscopic ultrasound, which showed a hypoechoic lesion in the head of pancreas. We went on to do a gallium-68 dotatate scan. A gallium-68 dotatate scan is a radiolabeled tracer that binds to somatostatin type 2 receptors. These somatostatin 2 receptors are in all neuroendocrine tissues, and they're overexpressed in neuroendocrine tumors. So as you can see, there's physiological tracer in the bladder, in the liver as well, but there's this avidly enhancing lesion that you can see in the area of the head of pancreas. So further confirming the presence of an insulin-secreting tumor in the head of pancreas. Just some background on an insulinoma. So endogenous hyperinsulinism was first recognized in 1927, and the first cure by removal of an insulinoma occurred in 1929. These are quite rare tumors, only about 4 per million, and they're virtually all islet cell tumors. Obviously, they secrete insulin autonomously, and the distribution is equal anatomically in the pancreas. They're usually very small lesions, less than 2 centimeters. They're usually isodent to the surrounding tissue, so might be difficult to pick up. So their overwhelming sign would be hypoglycemia. The age range is 17 to 86 years. The average age of pickup is 50, and it has a slightly more female preponderance. They can be sporadic or familial, and if they're familial, they're usually associated with the multiple endocrine neoplasia 1 syndrome. They can be solitary or multiple. They are usually benign, rarely malignant, and rarely ectopic. So in terms of localizing an insulinoma, yes, the mean duration of symptoms is usually 1.5 years. But patients have had symptoms for decades and have been misdiagnosed as having a neurological condition or psychiatric disorder because they get generalized tonic seizures, abnormal behavior, amnesia, blurred vision, etc. Some patients do have only postprandial symptoms in about 6%. So it's still something to consider in a patient with postprandial hypoglycemia. And weight gain does seem to be a prominent feature because patients are obviously eating more carbohydrates to correct their blood glucose. The differential for insulinoma, as we've discussed, would be sulfonylurea-induced factitious hypoglycemia. It would be non-insulinoma pancreatogenous hypoglycemic syndrome, as well as autoimmune hypoglycemia. In terms of localization studies, there's a few modalities of treatment. The least invasive or non-invasive modalities would be transabdominal ultrasound. A retrospective analysis of 31 patients only showed a 21% sensitivity of transabdominal ultrasound in picking up these lesions. As we said, they're small, they're isodent with the surrounding tissues, difficult to see on imaging. A CT scan is also about 55% sensitivity. An MRI scan, not much more. However, a gallium-68 dotatate scan with a PET CT has got a good positive predictive value of 90% and is more specific for an insulinoma. Other more invasive modalities, if for all the other patients who didn't have their lesions visualized on non-invasive modalities, they could undergo endoscopic ultrasound. It is the most sensitive in detecting very small focal lesions. And then a more invasive test would be selective arterial calcium stimulation. So in the selective arterial calcium stimulation test, you want to see how much insulin is being produced in the 3 anatomical regions of the pancreas. So the head of pancreas, the body, and the tail. So what they do is give the patient intravenous calcium. This seems to stimulate insulin release from insulinoma cells and not ordinary beta cells. So they cannulate the gastroduodenal artery. They measure insulin release in that artery after calcium stimulation. They cannulate the superior mesenteric artery, measure insulin release after calcium stimulation, as well as cannulate the splenic artery and measure insulin release after calcium infusion. So if there is a twofold greater increase in one of these territories, very suggestive that there's a lesion in the head of pancreas, for example, if there's a twofold increase in insulin secretion from the gastroduodenal artery. This is obviously very invasive. One good thing about this test is that it usually helps to differentiate between an insulinoma versus the non-insulinoma pancreatogenous hypoglycemic syndrome, which just has a general increase in beta cell mass. So there'll be increased insulin release from all 3 of these arterial territories. So most of the time, there's a 98% success rate in localizing the tumor when you combine endoscopic ultrasound with selective arterial calcium stimulation, as well as intra-op ultrasound and surgical palpation at the time of surgery. However, there's a small amount of patients whose tumors are not localized. Other emerging diagnostic modalities is a GLP-1 receptor scintigraphy. This is a GLP-1 targeted radio-labeled agent, so it's very specific for insulinomas in the pancreas. So just supportive treatment measures for anybody with hypoglycemia would be giving them glucose-containing fluids. Usually 15 to 20 grams is sufficient. Rechecking their glucose level in 10 to 15 minutes. You could also give intravenous boluses of 25 grams of dextrose water, usually 50 ml of 50% dextrose. The patient should feed frequently with readily available carbohydrates, readily absorbable carbohydrates, and you might maintain a dextrose water infusion of 5 to 10%, depending on what your patient's glucose level are. Patient should obviously be monitored closely and be having a glucose check at least hourly. Specifically, you want to treat the underlying cause. So if it is non-insulinoma pancreatogenous hypoglycemic syndrome, you want to do a partial pancreatic resection just to reduce the beta cell mass. If it's autoimmune hypoglycemia, it's an autoimmune condition, so you want to modulate the immune system with corticosteroids. And if it's an insulinoma, the first-line modality of treatment is a resection. So when we treat an insulinoma, a resection of the tumor is the treatment of choice. The least invasive would be a laparoscopic ultrasound-guided enucleation of the tumor, or distal pancreatectomy, depending on where the lesion is, or you could do a laparotomy. It really depends on the surgeon and where the location of the tumor is. So in this study of 224 patients, surgical resection cured 87.5% of patients with a solitary insulinoma. 2.2% of the patients developed diabetes after that. So obviously this just depends on how large the pancreatic resection is. And surgeries have gotten better, and there's been no perioperative mortality for an insulinoma resection recorded after 1941. In some patients, after removing the tumor, they've got persistent hypoglycemia. These are usually patients who actually have multiple tumors or recurrence of tumors because they've got multiple endocrine neoplasia 1, or they actually have metastatic disease. So other treatment modalities for insulinoma is endoscopic ultrasound-guided ethanol ablation. Ethanol is injected into the tumor mass. This is usually reserved for patients with a prohibitively high surgical risk or some reason that the surgery can't be done. And there's been some case series of patients that have been successfully treated with endoscopic ultrasound ethanol ablation. A few patients have gotten pancreatitis, but generally quick procedure. Patients have been discharged after 3 days with no complications. So you can consider medical treatment if the patients are awaiting surgery. If you couldn't find the insulinoma even during pancreatic exploration, you could consider medical treatment when the patient refuses surgery, or if the patient has a prohibitive surgical risk, if they've got unresectable metastatic disease, and the aim of the medical treatment is to control the symptomatic hypoglycemia. So some of the things we use, let me just recap what the beta cell looks like. So this is the beta cell, this is the GLUT2 receptor, it's the glucose sensing receptor. Glucose enters the cell, triggers phosphorylation of glucose and release of ATP. ATP binds to the nucleotide binding domain on the sulfonylurea 1 receptor. This causes closing of the potassium channel, which leads to depolarization of the membrane. Depolarization of the membrane then results in the voltage-gated calcium channel opening. This results in synthesis and release of insulin. So diazoxide inhibits insulin secretion by opening potassium ATP channels. This causes hyperpolarization of the membrane, reduces calcium influx, and therefore prevents insulin release of the cell. We usually dose it up to 1.2 grams a day in divided doses. Other medications we could use is somatostatin analogs. So on the beta cell, okay, this is where the diazoxide works by opening the potassium ATP channel and causing hyperpolarization of the membrane, which ultimately results in reduced insulin secretion. And then there's a somatostatin 2 receptor that's located next to the voltage-gated calcium channel. When somatostatin binds to this receptor, it inhibits or closes the calcium channel, and a similar effect is achieved that results in reduced insulin secretion. Many of the other drugs we mentioned before that cause hypoglycemia also, they work by blocking the potassium ATPase channel. So treatment of metastatic disease, other things to consider is mTOR inhibitors like everolimus for refractory cases. We also use external beam radiation therapy for symptom palliation. Because of the location of insulinoma, the most common place of metastasis is the liver. So you could also consider hepatic resection of metastases. You could consider hepatic artery embolization, radiofrequency ablation of hepatic mets, as well as cryoablation are also used. Some of them can be curative if all the tumor mass is removed. And then chemotherapy, a salvage treatment for refractory cases, a temozolomide-based regimen. And then more interestingly, lately, there's molecularly targeted therapies with tyrosine kinase inhibitors, as well as more specific peptide receptor radioligand therapies done with nuclear medicine. So if a patient did have a single adenoma, surgery is usually curative and there's a 95% recovery rate. Follow-up would normally be terminated at 6 months after that. However, malignant insulinomas do recur, so it's important to follow up the patient for a bit longer, and symptoms would normally recur 3 to 12 months post-resection. So back to our patient, she had quite a protracted course of illness. Her prolonged hospitalization and severe hypoglycemias were hampered by intravenous access issues, central line associated bloodstream infections, nosocomial sepsis, because of a BMI and the location of this adenoma close to the common bile duct, she couldn't have surgery done. Our medical GIT department assisted with partially successful endoscopic ultrasound ethanol ablation, and she was scheduled to have a repeat ethanol ablation. However, she wanted to go home for a bit because she'd spent so much time in hospital. And despite her, symptoms controlled on diazoxide, as well as frequent meals, she had a severe neuroglycopenic event at home that required ICU, and she unfortunately subsequently demised. So quite a broad topic, but when evaluating a non-diabetic patient with hypoglycemia, only really follow through if Whipple's triad is positive. The history is extremely important because factitious hypoglycemia is still a very common cause of hypoglycemia, and only really undertake imaging of an insulinoma when it's biochemically proven, because you could get an incidental lesion that you're chasing, or you might not see anything at all. And these are some of my references, and I'll take some questions.